Good evening. Welcome to the Fellows Online Lecture Series. My name is Melody Hrubes. I'm a non-operative sports medicine physician in New York. I work with Rothman Orthopedics in New York City. It is my pleasure tonight to introduce Mark Lavallee. He received both his undergraduate and medical school degrees from Pennsylvania State University. After completing a family medicine residency at York Hospital in Pennsylvania and a sports medicine fellowship at the Crozer Keystone Health System in Philadelphia, Pennsylvania, he acquired his certification as a strength and conditioning specialist from the NSCA. In 2013, Dr. Lavallee he started the sports medicine fellowship program at York Hospital and also a sports medicine program at Gettysburg College. In 2020, Dr. Lavallee moved to University of Pittsburgh Medical Center, where he sees both family medicine and sports medicine patients. He also runs a connective tissue clinic serving patients with Ehlers-Danlos syndrome, Marfan syndrome, and osteogenesis imperfecta. Dr. Lavallee is a fellow of both the American College of Sports Medicine and the American Medical Society for Sports Medicine. He has previously served on the board of AMSSM as associate editor of the Clinical Journal of Sports Medicine and had a faculty appointment as an assistant clinical professor of family medicine at Indiana University College of Medicine. He has been doing musculoskeletal ultrasound since 1998 and blood product injections, platelet-rich plasma or autologous blood, since 1999. The FAST by 10X, which is percutaneous tenotomy procedure, since 2013. On a national and international level, Dr. Lavallee has been the Independent Wrestling Federation Medical Director for the World Masters Weightlifting Championships 13 separate times all over the world. As a team physician for USA Weightlifting, for which he has served as chairman since 2012, he has covered numerous national and international events. He also covered the Olympic team trials prior to the Summer Games in 2000, 2004, and 2008. He covers USA boxing and professional boxing matches. For those of you who are on the Zoom call now, you're welcome to put your questions in the chat. I'll be going through them while Dr. Lavallee is speaking, and then at the end, we'll have time for questions that have come through and any questions that you have at that time. Dr. Lavallee?
Hi everyone. Thank you for staying up late. Probably in fellowship, maybe it's late, maybe it's not, but thank you for joining us. This is an amazing thing that AMSSM has put together through all the leadership from Melody and Andy and everyone else. So thanks for being here. I see some of my old fellows, Mike Galbraith, who was one of my fellows when I was at Notre Dame from 1998 to 2013, helped establish a program at the University of Notre Dame, and Mike was one of ours. He's now a program director down in Texas, I believe. So welcome to everybody. What I'm going to try to do, I have a ton of slides, 90 of them. You're gonna have access to all of them. I'm gonna try to go through this quickly and effectively through the three different components of spine care that is many times painless, sometimes painful in athletes. And you will see this if you do pre-par exams, if you see any sort of athletic preteen, teenager, high school or college, you will see this. If you haven't seen it, it will see you. So hopefully this will be very applicable. I have no financial disclosures. I will mention different products and procedures. I get no kickback from any of them. Anything with patients, I've been given written and oral permission to use them as recently as this morning. I'll address the natural history and treatment of scoliosis, kyphosis, and spondyloarthropathies. We'll talk about the difference between scoliosis and kyphosis. And how to treat it and when to send to surgery. I think that's really, really important anytime you do musculoskeletal medicine. So let's get our swerve on here. And of course, if you've worked at Notre Dame, you all know the Hunchback of Notre Dame. And it's not the Hunchback of Notre Dame South Bend, this is Notre Dame in Paris. Okay, so this is a Disney movie. I do not have permission to use that slide, so hopefully no one will sue me. But you know, these are common questions asked by athletes, parents, coaches, and even doctors. So can athletes continue to play with scoliosis? Well, the answer is absolutely. If the curve's under 30 degrees, very little risk in any type of sport. Even 30 to 90 degrees, they should be able to participate in most sports. It's when you get above 40 to 50 degrees curve, at the apex of one of the multiple curves in the lumbar or thoracic spine, then you have to start worrying about the bottom. Look at contact collision sports. Okay, these are things like motocross, roller coasters, bungee jumping, certain alpine and motorsports. So just think of those things because they don't, you don't think of a lot of them being contact or collision. Will bracing correct the curvature of the spine? Well, most braces have proven not to permanently reduce curvature. Now, there's an asterisk there. We're going to talk a little bit about the derotational brace, which has been on the scene for less than 10 years. It was actually created by Dr. Rigaud, who is a Spanish. He's from Barcelona, Spain. His daughter had scoliosis, and he created this. He said, we can do better. And it's amazing what this brace has done. We'll talk about Dr. Paul Sponseller's paper mentioned here later. So how long must a brace be worn to be effective? Okay. The idea was how much? Well, 23 hours a day is what literature shows. But remember, we're dealing with what? We're dealing with teenagers and little kids. Getting them to do anything for 23 hours a day other than complaining and eating and maybe going to the bathroom is about the hardest thing to do. So 18 hours a day or better is what they need to wear a brace. How long must the brace be worn until it's discontinued? Until their growth plates are closed. And we're going to talk about how we measure that using things like the Risser score and the Sanders maturation scoring system. Also, we also want to see no vertical growth. I have been stumped many times by the X-rays that showed their growth plates are closed, and somehow magically they grow another 2 inches. So we want to monitor that. Does manipulation therapy help correct curvature of the spine? Some people will tell you, our friends who are chiropractors and in manual treatments, they will talk, yes, they'll correct spine. Micro movements are helpful, but macro movements are what we're talking about. Can they correct macro curves, not micro curves? Okay, we'll talk a little bit about Schroth therapy, which we'll talk about supporting some of these different changes we're talking about in bracing the spine and how Schroth therapy plays into that. Okay, so here's a definition. We're a definition: prevalence, incidence, signs and symptoms, risk and genetic factors, differential diagnosis, which will be huge. If your differential is one thing I always hammer my residents and fellows is keep that differential nice and wide, or else you're going to miss stuff. The history is pretty straightforward. The physical exam is pretty straightforward. We'll jump into imaging and treatment, and then when to refer to surgery if we have time. So scoliosis is a fixed lateral curve of the spine. Okay, kyphoscoliosis is a combination of lateral and AP curvature of the spine. Just setting, this is basic definition stuff. So when we look at the spine, we talk about kyphosis. That's not just the whole spine. That's really the thoracic spine we're talking about. That exaggerated AP curve of the thoracic spine. Lordosis is exaggerated of the lumbar spine. How do you remember that? Okay, here's my trick. Lordosis, lumbar, they both begin with L. Okay, that's how you can remember it. I'm a very simple man. I'm not that smart. So this is little words like this can be helpful. The next is a prevalence and incidence. 3 to 5% of the curves that you're going to see are going to have not only changes, are going to have changes in the bony formation. Okay, you're going to see deviated and curved spinous processes. You're going to see ribs that are convexed and narrowed in the thoracic cavity. You may even see thoracic vertebral bodies or lumbar vertebral bodies that are not symmetric. Okay, so this is one thing we're going to be looking at. That's why just pure manipulation isn't going to help. You need everything's dynamic, and the beauty of kids with this, if you get and we'll go through the different types of scoliosis, infantile, childhood, and adolescent. They're still growing. Okay, and if you ever think of, I use an example of phototropism. If someone gives you a flower and you aim it, you put it on your windowsill, and it grows towards the light. And you take that flower and you turn it 180 degrees. Over time, the flower will go back towards the sunlight. We're using that similar idea of tension and traction on the convex and concave sides to reshape the spine. The younger they are, the more open their growth plates, the more chance we can correct some of these things without surgery. And this is where it's so essential as you as primary care sports medicine providers. Because if you can prevent $100,000 Harrington rods being put into your patient, you're going to see them a great service. Okay, so gender, we've got females and males. As we can see, this is definitely affects the females greater than the males, especially when you get to the higher curves. Look at that, 10-to-1 for greater than 30-degree curve apex curves. Smaller ones, you know, it seem to affect the males and females close to 1.4-to-1. Progression is much higher in females. And remember this, we're going to be talking, 90% of these are adolescent based, okay? We'll talk about the infantile and childhood in a little bit, but the majority that you're going to see, the majority that I see, are adolescent teenage girls. Okay, so here we go. So idiopathic sclerosis in school-age kids is 2 to 4%. Okay, that's a big number. If you think there's 300 kids in a school, you know, 4% of 300, that's 12 kids that will have scoliosis. Many won't, most won't need surgery, but they may need to be followed. Okay, and you can follow them in most countries, third world countries, they follow them with exams. In America, they do exams and occasionally X-ray. So here's really the thing I want you to remember. If we look at infantile, which is those under 3, juvenile 3 to 10, and then really about 10, anytime, you know, is pre-puberty, 10 plus nowadays, that's 75 to 80% of the cases. Okay, so we're going to spend a lot of time on the adolescent. We'll spend a little bit of time on these other ones. So how do you find this? This is many times found by moms, school nurses, grandmas. They look at little, you know, little Jane, and they notice that her hip skirt is not even. The hem of her, the belt of her skirt is not even. They'll see that one shoulder blade is higher or lower than the others. Now, interestingly enough, I have scoliosis. I never needed surgery, but the way that I, you know, I didn't know it at the time, but I knew when I was sitting at church and I leaned back on the pew, that one shoulder blade went above the edge of the pew and one went below. Never thought that until I became a physician and started doing this. I went, oh, that would have been a way to figure this out when I was a teenager. So there's little things like that that they may present with. It's very overt. It's usually seen by someone who looks at them from behind, almost never picked up by the patient or athlete themselves. So here's another public service announcement for some of you younger people, fellows. This woman is called Madonna, and I was infatuated with her back in the day. She was a singer. She's now, I think, 65. I think she's like in a nursing home somewhere. But this is her daughter, Lourdes, and here you can see she did this public service now because why? Here's Lourdes. You can see just underneath her Boston brace underneath there. Okay, so there's some genetic factors. We talked about family history. There's variable penetrance, and it favors what we think is an autosomal dominant pattern, and it does seem to ride heavily on the maternal side. So taking that history, and your sisters and your moms, grandmas, aunts, uncles have this. Take that history because you'll be surprised that you'll probably find someone with something. So what does the spine look like? You know, here's a spine, an actual spine, and you can see that when you start looking, when you look at this apex curve, you can see here that it's not a normal looking vertebral body. It's compressed, it's squished. It's almost like soft Play-Doh. Now, if you get this early on when the body's still changing, you can actually change some of that, small bits and pieces, not extravagant. This is, you know, this is close to a 70-degree curve right here. And then you have a compensatory curve up here. So we always talk about the major curve and compensatory curve. This would be called a double major curve. Now, one thing we notice with adolescents, and this one comes when, and you'll see a great case of this, one of the cases I present here in a minute, of proprioception and vibratory sense effect. They will have deficits in this, and especially in certain sports where there's movement, ball sports like racquetballs, tennis, lacrosse, they'll see a decrease in their ability. They'll fall more. Their game is off as they go through puberty with this problem, because their brain is saying their center of gravity is one place, and their body's saying their center of gravity is over here. Okay. Here's your differential. I'm going to encourage you all to come back to this slide when you're studying for your CAQ, because this is where you can run into problems. One is, you know, there's congenital scoliosis. You've got Klippel-Feil or Vactal syndrome. The way I always say this, and you'll see Klippel-Feil, you go, okay, show me the see 4 in this X-ray, and you go, can't see it. This is where they have fusion of multiple levels. Myelomeningocele, neuromuscular scoliosis, upper motor neuron lesions like Friedreich's ataxia, cerebral palsy, Charcot-Marie-Tooth. We'll show some pictures of the foot structure in that, muscular dystrophies. So all these different things. When you look at lower motor neurons, we talk about polio. You see some post-polio syndromes and issues with scoliosis in adults with post-polio syndrome, spina bifida, of course. The functional, the most common cause that is easily correctable is right here, gentlemen and ladies. Leg length inequality. They'll come in and no one ever measures their leg length. No one gets an AP of their pelvis and they see the difference. Then you've got Shermans diurnal kyphosis or Schmorl's nodes with pathognomic, we'll go over that, end plate fractures. Secondary kyphosis, the bone demineralization, we call this osteoporosis. Okay, so remember, we're not just talking about athletes. Your athletes come in all shapes and sizes. Okay, this could be your 65-year-old marathon runner. Okay, you look at all these things, right? Of course, we'll talk about spondylolisthesis, herniated disc, and leg length discrepancy. Don't forget your osteoid osteomas and herniated disc and discitis. So this is usually a painless back problem. Okay, it's noticed by someone else, uneven shoulders, and someone's bending over, and you get this uneven rib height. Okay, you may not see this curve here. You see this little curve here? You probably won't see that. Okay, we have a very well-insulated American population, so you don't really see ribs as much. So here's what you're gonna see. You're gonna see things like a kid with a lowered shoulder, but then you look and this pelvis is dropped. We lift this leg up, and all of a sudden their spine straightens. Generally speaking, when you see unilateral curve, that is probably a leg length discrepancy issue. If you see a major and minor curve or compensatory curve, that's usually congenital adolescent scoliosis and can prove otherwise. If you see a picture like this, a high arch foot or a cavus foot, which has a shortened midfoot, which makes it look like the much shortened midfoot in comparison to the ankle. Think Charcot-Marie-Tooth. They're gonna have issues. If you see someone like this who's got arms like a gorilla and a carrying angle like this and pectus deformities, think Marfan. If you see someone with scars, the purplish scars on their skin, or the double jointed, think Ehlers-Danlos. If you see capillary lay spots, think neurofibromatosis. Okay. Physical exam is pretty straightforward. This is your $20 fix. Once again, I'm not selling any products here, but it's called the scoliometer, and it's just basically a bevel. They use these on boats for pitch and yacht, but this basically will give you an estimated Cobb angle. We'll talk about this in a second. A scoliometer reading, you take that and multiply it by, it's 7 degrees, multiply it times 3, and it gives you an estimated Cobb angle. It's pretty darn close. And you basically take this and run it up and down the spine, and you look for where the bevel it goes, and you read the number. Okay, very, very simple. Now here's the thing. You guys can actually go on your phones, and you can take your smartphone, woohoo, like this, okay? You can download an app, and it actually turns your smartphone, you put your smartphone on the back of someone's back, and it becomes a scoliometer. Pretty swift. I think it's like $4.99. You actually have to pay for it. It's not free. So how do we measure this? You decided someone's got scoliosis, you suspect, so you order an X-ray. You get that X-ray. Now you've got this, oh my gosh, it's curved. How do I measure it? You just send it off. I hope you guys just won't send it off to the radiologist and wait for a report. I hope you will take out your tools. We used to have these things called film in a dark room, and we have wax pencils, and we use this thing called a goniometer, and we actually make the measurements in real life. Now you can do everything electronically using PACS. It's much nicer. So what you can do is you can do a measurement, and this is how you do an actual Cobb angle. You'll go to the first affected, the top of the first affected. You're going to draw across from there, and then the computer will make a 90-degree angle and jet it this way. You go to the bottom affected, do the same. It will jet it, and it'll give you a number. It's a 58. Okay, you can do direct measurement. That's sort of where we've moved to with the use of electronics in measurement in PAC system. So you can do Cobb or direct measurement. In direct measurement, you just draw a line here where they intersect. That's your apex right here. So this is your apex. So you would say that was L3, let's say, and you put the angle. So the apex is L3, 58 degrees, okay? So we've got our stable vertebrae above. We've got our first affected and our terminal vertebrae. Okay, so let's bring this here. This is one of my older films, and it's wax pencil, guys. This is what we used to do in the old days. You can see right here, here's my right angle. So here's my first affected vertebrae, okay, and I drew a line here. Then I had my last affected vertebrae, okay, and here, and this angle right here. Yep, that's it. That's your 46. That's your 46-degree angle, okay. And then you can see the compensatory curve. We did that up here too, okay. And this is how we did in the old-fashioned days. You're going to order an AP standing. I'm going to say standing. I'm going to say not lying down, standing. You want standing, and you want the problem with this particular picture, lots of gas, and you can barely see the iliac crests in the bottom. You're going to need to see those iliac crests to do your risk of scoring. Okay. Now, as you look at that, which is the most common? This is your double major curve. This is what you're going to see: the major curve and the minor curve. How can you tell the difference? The major curve is always a bigger number, and the minor curve is always a smaller number. Okay, but you're going to measure this. Okay, your direct measurement or Cobb angle, and then you're going to measure the secondary curve. Some people go, "What about this? This is a curve here." Yes, you can say that, and you can say this is a departure curve here. Really, you got to look big picture. You got to step back, look at those X-rays, look for the two curves. Okay, rarely do we go for they have three curves. When you start thinking about that, you think of some really, syringomyelia and some other muscular dystrophies of the spine. Okay, when you see single curves like this that are more sweeping, this is many times a leg length discrepancy, trauma, or what we often see is malformation of the vertebral body, an actual wedge, what we call a wedge vertebrae. So you look and like, wow, everything looks pretty straight, and they got boop, you got a little pie-shaped vertebrae. Okay. So depending on where the majority of the curve is, thoracic, thoracolumbar, or lumbar. So red flags, when do you get really nervous? Okay, you're gonna get nervous when you see other abnormalities on X-rays, excessive kyphosis, okay? When this is all happening before the age of 10 or 11, because that's gonna be either juvenile or infantile and much rarer. And you're gonna really wanna have a low threshold, unless you're doing a lot of this in your clinic, to refer to a pediatric orthopedic spine surgeon. When you see rapid progression, when you see patient spines progressing 10, 15 degrees in a 4 to 6 month period. And then of course, if they have associated conditions. So this is my first case, and it's quite extensive. This is a 13-year-old, 47-kilo runner that came to me, 8th grade runner. First, okay, straight across looks good here. Here, look at this posterior indent here. You see the shoulders look initially straight across, but when you can see actually the right shoulder is lower, and you can see the scapula is actually sort of dyskinetic and coming out. When he bends over, you can see this also hump here. Okay, that's not really a hump. That's really actually the posterior ribs malformed, pushing posteriorly, they're floating, and you can see it much more impressive here. MRI, of course, was negative for spinal pathology, neurologically intact. Scoliometer came out at 22 degrees. So when we ran the scoliometer 22, multiply that times 3, it's going to give us a predicted Cobb angle before we even get an X-ray of 66 degrees. Not probably good. So here's his X-ray. Initially, we thought it was 85, but you can see here, it was a little washed out. I apologize for the nature of these pictures, but you can see here, he's got a substantial curve of about 70 degrees. Okay, this is flipped around. He doesn't have situs inversus. Stomach bubble. We also checked him for kyphosis and lordosis. That was all pretty good. So when we started doing X-rays, we coned it in, and let's see if this works. Come on, technology. Don't let me down. Okay. So if you look carefully, there's one of the things we talked about. When we see something this exaggerated, I worry about a wedge vertebrae. Okay, so you can see right here, or maybe hope you can see, this does not look like a typical, rectilinear vertebrae. Okay, here's your angle. Okay, and here's that picture of what a wedge vertebrae. So this was born this way. So this is all the corrective stuff we were talking about is out the window when you have a congenital component like this. You're going to probably need surgery. Okay, and here's the Cobb angle measurement that shows 64 degrees. So here's what's called an anterior approach or thoracotomy approach. And the way you know that, it goes underneath the axilla and forward. It's not through the belly, but this is an anterior approach. You can see this rib hump. Okay, you can see this poor guy has been, yeah, this was summer, and then this was him after surgery. This is almost a year apart. Most of these surgeries are done between May and June because these teenagers want the summer to recover. Okay, so they do a ton of these in the summertime because it's just easier for the kids being off from school. This is what happened underneath, and I was able to get these X-rays from the surgeon. And you can see this is quite some time ago. This is one of the first cases that I took care of. But this is the Harrington rods. This takes about 12 hours. This is not a surgery you want your patients to go through. Once they have this, you know, they can't ride roller coasters. You can imagine the shock to the spine if you're loading, if you get hit in the pelvis on a motorcycle jump, the snowboarding, bungee jumping. Their life will be limited, but they'll be straighter and they'll have some issues. They'll do better down the road. Now, here's how do we tell this? This is, you know, skeletal maturation, because it's all key to how when to embrace, when to send, when are they out of the woods. You know, if someone's got a 40-degree curve and they're a Risser 4, I'm happy with them. If they're 30-degree curve and they're a Risser 1, I'm really concerned, and I'll show you the numbers. So when I explain this to patients, and I'm looking at this X-ray, and I'm looking at that iliac crest, and I'm looking at the beginning of the iliac apophysitis, it shows up when girls get period. Before the period, there's nothing there. Once they get their menarche, it starts, and then it's like a little inchworm. It inches its way up and over. So think of this as four quarters: 25%, 50%, 75%, 100%. So each quarter of migration of that hypophysis across the iliac crest is your Risser scoring. Now, once you get to the peak, you're almost home free. So if you get to the top and they're not progressing, then they probably won't need surgery. But the problem with this scoring system, and we've moved away from this in the last 10 years, is because of the gas pattern. These kids eat a lot of Taco Bell and processed food, so they're full of gas. And it always almost clouds. Now you got two sides to look at, but it gets tough. So we've moved to the Sanders maturation scoring system. Now here's where we still use this. You can see what's the rate of progression, what's the probability it's going to progress. Obviously, when it's a Risser score 1 or 2, if you're a lower curve, it's a 22% chance it's going to progress. If you have 20 to 29 and you're Risser 1 or 2, look at that, 68% will progress, 2/3. Remember that. So higher numbers at the lower Risser is when you get concerned. It's when you get to the higher numbers, look at it barely progresses. Okay, not as much. This is what we call, if you order bone age films. Okay, this is what they're talking about. It's a hand X-ray, and it's basically looking at the growth plates. It's rated 1 through 8. 8 is fully skeletally mature. Okay, when we look at this, I call this a cupcake and the icing on the cupcake, right? Cupcake, icing on the cupcake. When I look at this, this reminds me of ice cream cone and ice cream on an ice cream cone. Okay, when we see 1, 2, 3, 4, we look at them, the tips close first, then the middle phalanx, proximal phalanx, the metacarpals, and then eventually the distal radius. Okay, when you see how them close, they're at an 8. Okay, so that's how we age them. Moving on to another, the Shermans juvenile kyphosis. This is a Schwarz node. You can see it in 2 ways here. You have to have at least 2 vertebrae with an end plate fracture. Okay, that's what these things are. These are end plate fractures, okay, and compression. You can see the sclerosis and compression here. It looks like someone took a hole punch and punched the anterior, usually superior edge of the vertebrae. And so think of Shermans, Schwarz nodes, SCH, really easy to remember. It just rolls off the tongue. Shermans, Schwarz nodes. Okay, and this is for kyphosis. This is bracing. Usually is for pain and not kyphosis. This is one that is painful. Shermans is painful because what happens is it compresses the anterior chest and the chest cavity. Okay, So this is what every teenager fears when they come to your office, that they're going to get. The old, Forrest Gump leg braces, or in this case, the metal corset. Okay, we don't use this anymore. We have some pretty cool stuff with plastics, high dynamic plastics. Rarely need surgery for kyphosis, and we rarely need to brace. We brace between about 50 degrees and about 50. So here's my case number 2. This is a nice little family. The sister had scoliosis. The brother has kyphosis. You can't really tell much from the front view. You can tell that our patient, who's a 13-year-old tennis player and skier, had painful chest deformity and actually came in for what he was diagnosed with was costochondritis. And then they thought he had Marfan syndrome. So you could say, well, his arms look really long. Well, it's not that his arms look long, it's that his chest looks small and his chest deformity. So we started looking and we got an X-ray, and lo and behold, this is not an X-ray, but this is one of the scout films from the CT. But you can see he had a 105-degree kyphotic angle. So that means his whole chest wall was getting crunched. So he had significant pectus excavatum. His apex was at T8 here. You can see it was over, this is like more than 90 degrees, right? And his Risser score was low too. And his SMS was 4, so it was low. So here's what we ended up trying, this derotational brace. It was ineffective. So he quickly went to surgery. This is what I want to show you. Here's the before and afters. Okay, pretty impressive. He had, at 15, he had the RF at Penn State last year. And you can just see, this is not an easy surgery. Not an easy surgery, but look at this. Here's him with his dad. He gained 6 inches. He went from being super short, and now look at, he's super smiling because now he's taller than his dad. Look at the change in his chest before and after surgery. Hugely changed the impact of this kid's life, not just pain-wise. Also, it was compressing his internal organs. He had his PFTs improved, his cardiovascular access improved, his tennis game improved because his center of gravity had changed. Okay, he was able to resume tennis, skiing without an issue. He's not allowed to do jumps or double black diamonds, but did very, very well. So when we talk about non-surgical treatments, we want to talk about the probability, is it going to progress or not? The first thing we look at is the nature of the curve, their age, and the risk of progression. So if you can see, if you start off with a low curve and you can make it to 16, the chance it's going to progress is almost 0. But as that curve goes up to the 20s, 30s to 60, it continues to progress just on age alone. We're just looking at age and curvature at presentation. So we start looking at, okay, what do we do? So basically under 20, we monitor, okay, with X-ray. 20 to 29, we're going to do X-rays every 6 months because we want to see what they're looking like in their bone maturity and following that. When they get to 30 to 40, we start considering bracing. We've actually moved this. I'm starting to brace at 25 because the earlier I brace, the better outcomes I'm getting. Okay, so this is one where actually starting earlier can sometimes, if your prediction is it's going to occur quicker, then jump on the bracing sooner when they have more chance, more pliability, more chance of growth. The more chance they're going to grow vertically, the better chance that you can help this with a derotational brace. So what is the management? This is the old management style. So you've made the determination they have scoliosis, you've ruled out other things. Now you're looking at a mom and a dad, and you're looking at a very scared teenage, most likely girl. And this is what they all worry. Doc's going to put me in a brace, or doc's going to send me for surgery. This brace is so thin that, they usually wear a t-shirt, and then they'll wear anything over top of it. No one will know they're in a brace unless they get punched. If they get punched, someone's going to break some knuckles because it will not give. So what we're looking at is we really want to start this earlier, before Risser 3 and men before 4. Bracing with this is what the insurance is always going to pay for. It runs about $1,000 to $1,500. Okay, maybe you can get it under $1,000, but it's not cheap. but all insurances will pay for it because this is what's indicated. It's the old Boston brace, what we call 0-degree anti-lordotic thoracic lumbar sacral orthoses, or TLSO. Okay. This is the new thing. This is the one that is basically the same material, okay, except it's got some color to it. But notice it's not even. You've got holes cut out over here, and you've got a hip buttress on this side. You've got an arm wedge up with jacking up this shoulder. You can see this is down low, and you can see there's a twist here. And actually, there's actually a wedge here into the hip, almost like a corset. It looks uncomfortable, and it is slightly uncomfortable to start with. But what we're trying to do is we're trying to put pressure on the concave side, the convex side, to help the concave side rotate out. Okay, so it's a lighter brace, more twisted in appearance. Now here's the thing: this data, most of the data is just since 2014 and newer. So this is the only brace to improve a curve up to 40% in braced patients. Now let me show you some pictures. Okay, well before that we'll get to some more studies here. So this is a study that came out in 2014, the one I alluded to, which showed that when they're in a brace, it actually derotates the spine, where you can see improvement between 10 and 40 degrees while they're in the brace. Now that's all good, right? Great, doc. It's good while it's in the brace. You take it off like a spring, it uncoils back to the way it was. Here's the thing. Within a month, we will take X-rays and we'll see befores and afters in the brace. And we start looking, now look at this one. This is a before. You can see the hip height angle change. Now it's pretty much straight across. When we look at this posterior view in this patient, you can see dyskinetic movement of the right scapula, where it's more in line on the left. Okay, now here's a great example. I like to use this because this is one patient, and you can see this is 2017, and look at the dates. So on the left is October 2017 and 1 month. We always do a 1 month X-ray in and out of the brace. So you get the brace, okay, they put it on, they torque it down, and all of a sudden you start straightening up. Now, so here, if we look at this patient, their apex here is at T9. This is a double major curve, 1, 2. You can see the apex here down at L4 and T9, and this is 36-degree curve. Okay, we decided to brace her sooner because she had a low Risser score, Risser 1. She was 13. Dad was really tall. Mom was really tall. She was going to grow a lot. So we had the pre-test prediction is that this was going to progress. So we put her in the brace. Look at this. 5 weeks in the brace. How do we know it's braced? Here's the buckles. Okay. So that was almost perfectly corrected in 5 weeks in the brace. Now we take the brace off. She uncoils a little bit, right? She uncoils to 24. So we saw an improvement of 12 degrees in 1 month. So this is where it's like, aha, poof, all that stuff they told you bracing does not help, out the window. But it's in the right case. It has to be a low risser, has to have a lot of growth potential, has to start off with a high number. Okay, so not everyone will do this. A lot of people just get the Boston brace or nothing at all. But this is where, if you have the right case, you can truly impact a child's life. Case number 4. 2-year-old male. This is one of my patients from my EDS clinic, has arthrochalasia type. This is a rare form, but they have infantile scoliosis. If there's anything that freaks out a pediatric orthopedic spine, is infantile scoliosis. Why? Because their spines are bad, they're floppy, they're gonna you need numerous surgeries. I've had 2 patients with the exact same EDS arthrochalasia type, one that progressed to needing surgery, and this one that did not. Okay, so it doesn't work on everybody, but this is one of our success stories. So here you can see our young little patient here at 2 years of age, okay, 51-degree curve, and it's a purely lumbar curve. This is November of 18. We put in the Boston brace, the Rigo brace. This is now August, 9 months later, 23-degree curve, an impressive improvement. Okay, now that sounds great, but it's in the brace. So we take off the brace and he recoils back 10 degrees more. Still, going from 51 to 33 is an improvement in a young kid. Remember, kids grow like crazy. Okay, if you had to instrument this, you'd be doing revision surgery all the time. The other thing that they do is casting. So at this age, a pediatric spine surgeon is going to do serial casting every month. very irritating to the skin. These kids may not all be potty trained, and that gets really stinky no matter how good of a parent you are. So this is, they can take this off, they can wash and wipe it, and it's very easy to put on. So here's this fourth case. And remember, we started 2018, 2019, now this is 2020. 2 years later, look at that curve. The reason we had this improvement is because of the derotational component, and the brace can easily be altered, and we almost corrected it by 40 degrees in this kid in over a 2-year period. Okay, here's what we started with, here's what we finished with. We still have him in a brace. He's now obviously 5 years old and doing quite well. So when do you refer to an orthopedic spine specialist? When it's non-braceable curve and the apex is higher than T6, when you're getting close to the cervical spine. In newborns, infants, any child under the age of 10, if you're not doing this regularly, get it to a pediatric spine surgeon. Curvatures with high spondylolysis on top of scoliosis, and any sort of curvature related to severe trauma. Surgical, here's your traditional Harrington rods, very big surgery. You can see it here. It's a big posterior approach scar. Okay. You're going to do, they're not going to really touch this nowadays until at least a Cobb angle of 50. They have an anterior and posterior approach. Here's the anterior approach. We saw that in our first patient we talked about. And here's your posterior approach. Okay, the patient, I mean, it's a very interesting surgery because it's pretty gruesome as they're putting in the pedicle screws, and eventually they're going to be cranking, they're going to be cutting a lot of interspinous ligaments to loosen up the spine, and then it's all really brute force carpentry, if you would ask me. You want them to be as skeleton mature as possible, so you only do the surgery once. One of the things, the vector, which came out of Texas about 15 years ago, this is one we use in adolescents that are still growing a lot, or mostly infants and mostly children. So what this does, instead of instrumenting the spine, you're basically tagging the ribs and causing the splayed up or sprayed outside. You're anchoring this, so as it grows, it holds this static, and this will correct the curve by growing. This works really nice. The problem with this is, it's sort of like the rib spreader, is here's a study came out between 1990 and 2003. This is the biggest study out of Smith et al. Out of Texas. I think it was Houston Medical Center. 257 patients, 455 adverse effects. 75% were minor. 5% were life-threatening or fatal. Okay, 5%. That means you're taking a condition which it may or may not be lethal, but 5% die from this. You've got to really be, and the Harrington rod is about 2%. We'll have life-threatening or fatal outcomes with the Harrington rod. So it's not without issue. A lot of these were 41% were surgical management resolved the issue, another 40% medical, and 12% no intervention. You can see the complications: pulmonary infection, device migration, and breakage were 20%. So this is a big thing. Metal breaks in humans. Anybody tells you differently, metal the stress of metal breaks in humans. Eventually, no surgical advances. Thoracoscopic approach. This is a 4-portal approach, so they can do thoracoscopically. It's getting more and more accepted. Of course, every teenage girl would like this approach because there's no scar, but this also lengthens the surgery by about 4 to 6 hours. It really needs to be done by someone who does a lot of it. There's intervertebral body stapling, where they go in, they lysis the interspices spinal ligaments, and then they drill holes, and they use orthocord to do body stapling. This has shown most benefit in the childhood population, not adolescent. Wedge osteotomies can sometimes be helpful when you've got congenital issues. Once again, this is for a very specific population. Okay, that's the scoliosis and kyphosis component. We're going to jump right into spondyloarthropathies. I've got about 10-15 minutes for this. So spondylolysis, spondylolisthesis. Lysis means to break. Listhesis means to move or slide. You can see for spondylolisthesis, you have the bilateral pars defects. If you have a unilateral pars, you're not going to have movement unless you've got another associated fracture maybe in the vertebral body. But generally, if you only have a unilateral fracture, whether it's chronic or acute, you're not going to see movement. You just have a lysis, not a lethesis. Okay, so it's the pars interarticularis. Remember that, guys, pars interarticularis. That's the defect. We'll go over some pictures of that here in a minute. Now, there's different types of lethesis and ventral translational migration of the anterior and posterior product of the spine. There's congenital, isthmic, degenerative, traumatic, and pathologic. A lot of this is what we think that we see in sports is isthmic. Some people will argue that it's actually traumatic, that the trauma actually does not occur at presentation. The trauma occurs between the ages of 5 and 6 years of age. They have their fracture of their part. Everything's fine until little Bobby or little Jane hit club sports or some sort of new activity and have an injury to the fibrous union that has gone across their fracture, and we've got a chronic injury, an acute on chronic. So here's the defects on film. 6% of the population by age 18 will have a pars defect. Okay, I didn't know I had one until I had some X-rays from another injury when I was 20 years old. That they found out that I had this, and I don't even remember it being a problem or having an injury, but it was old. 4% of 6-year-olds have this. 8 to 14% of elite adolescent athletes. 50% may progress to lethesis if they have another injury. 95% of this occurs at L5. So they're really looking at the L5 region. And they think that's because of the departure angle of the sacrum and pelvis and how it loads. And only 32 to 47% of adolescent athletes evaluated for back pain have spondylolysis. I really want you guys and ladies to remember that 1/3 to half of adolescents evaluated for back pain have a spondylolysis. That is a huge number. It should be on the top of the differential, more than muscle spasm or hamstring pull. Okay. It's got a 2-to-1 male over female ratio. Females have higher risk of spondylolisthesis. Okay, for bilateral, we do not know why that is. There's a higher incidence in the Caucasian over the African American population, and it's got a really big issue in the Eskimo and Native Alaskan population, and they think that's because of short arms, short legs for energy conservation over time. But they have these like sort of thicker, stockier torsos, and somehow that plays a role. Not much more than we know about that. Just that they have a high predilection of this in the Eskimo population. There's also family history spondylosis, occult spinobific, and you have to keep an eye out for that. Of course, Shermans, and then extensor and rotation activity seem to aggravate it. We can't say it causes it, but if you have it, it will be aggravated. Here's some sports where it seems to be a little bit more prominent. You can all think of these, whether it's gymnastics, weightlifting, pole vaulting. Just go through them. Diving, not scuba, rowing, wrestling, javelin. All these are going to have hyperextension components and rotational components at the trunk and lumbar area. So where is this plastic interventricular pars interventricularis? So if we all look at that Scotty Dog, here's the doggy's ear and snout, and here's the dog collar, here's the front paw, back paw, and torso. Wouldn't it be nice if all X-rays looked like that? They never seem to. They're over-rotated or under-rotated, but you have to sort of really look for it. But here's it when it separates. Here's that the head is decapitated from the body, and we see migration there. Okay. So natural history: 500 first graders in the development of spine did not have produced pain. So we looked at a whole bunch of this study. I'm going to misquote it, but it was a pediatric study where they somehow got X-rays, and there was an X-ray review from an ER, and so they reviewed the X-rays and they looked at what they presented with. So any spinal films of under first graders, so 5 to 6-year-olds, and they said, did they have any history of back pain? Many of these X-rays were for other reasons, pelvic issues or hip pain or something. Progression to spondylolisthesis occurs during adolescent growth spurt. No risk of spondylolisthesis in unilateral defects. And then this is a 45-year longitudinal study they were looking at general population. So the adolescent presenting history, usually axial back pain, worse with activity and hyperextension, relief with rest. Neurologic compromise is uncommon. So if they have ridiculous symptoms that may steer you in a different direction. Still should be your differential. Of course, you can have two issues at once, but generally it's going to be something else causing that pain. You're going to be looking on the X-ray for callus formation, foraminal stenosis, and disc herniation. You're going to look for hyperlordotic posture, lumbosacral tendons, hamstring tightness is usually there. And then we have the old hyperextension rotation, so a stork test, which is one leg hyperextension test. And then this has a relatively poor sensitivity and specificity, but we continue to do it because it's one of the few tests that we have for this particular component. Really, the diagnosis is made by radiography. So here's your Scotty Dog. Okay, you get 4 views. This is obviously, here's the ear, snout, front paw, body. Okay, and we don't see anything here, but on this one, here's your snout, here's your ear, here's your dog collar, here's your front paw, here's the body. Okay, so this is an isthmic fracture. Okay, it's not migrated. So another thing we can use, once you get this X-ray, what do? Is this a new or old? You know, and like we said, we think most of these are old, what we call acute on chronic versus acute. So we have many options. There's basically 3 tests: Spec scans, or Technetium 99 scans. We have bone scans, we call CT scans, and then we have MRI. We'll talk about the 3 because this continues to sort of go back and forth on what's the most common and the most accepted. I think it depends on a couple things. It depends on where you practice in America. It depends on what your insurance providers are going to make easy for you to, you know, if it's super hard to get MRIs and super expensive, you're going to probably order Spec and CT scan. If it's easier to order MRI, a lot of people go with MRI. So it sort of depends on where you train and who you train under, and also the insurance people. So here we use a radio tracer, Technetium 99, to detect metabolically active bone. That's going to be your Technetium 99. And then Spec scan is basically this single photon emission CT that they're going to really scope in real quickly. We'll show some pictures here in a sec. Can help stage and know the stage the spondylolysis, and a positive scan often correlates with painful parts. So here's your Spec scan. And you can see the increased uptake in the posterior elements, none in the anterior elements, none in the vertebral bodies. And we're right there at L5. Here's an AP component. This is a bilateral. You can see a lot more here on the right than the left. You can see a little uptake here in the kidneys, okay, and in the upper spine. Also, these are iliac growth plates. That's why they light up, is because your growth plates are physes are there. So with CT scan, you're going to want to get 1 millimeter cuts. You're going to have to make sure you put that in. If you don't, basically, if you order, if you put the diagnosis in, they'll get the 1 millimeter cuts. If not, you get a 2 or 3 and you may miss it. You're going to get great bony detail. You're not going to know if it's new or old unless you can see that the edges are rounded and it looks more chronic. And you're not going to be able to evaluate. You can evaluate bony healing over time to see if you get some healing, and you can stage lesions. So here's a couple of things. So here's a beautiful example of the difference between a 3D recon and a 2D CT. Here's your L3. So we've got an issue here at L5, okay, which we thought about, but here's also one in L3. This is a trauma. So you can see this is a traumatic 2-level part, okay, very easily. You can't miss it, even with the arrows there, you can see it. So actually, it's much cooler looking with a 3D, but it's not as easy to see. It's hard to see that down there. Okay, you can't see the L3 because it's pedicles. So, you know, you have to rotate it around and look. As cool as this is, the patients think it's like super cool. The 2D sometimes is much easier, right? So you're going to find these hairline fractures. You're going to be able to, and a CT scan is much cheaper to order that at 12 weeks follow-up. It's also more radiation. You have to think about that if you've got a young lady, because, you know, you're hitting her ovaries twice with high dose radiation compared to an X-ray or an MR, which is no radiation. Okay, one thing you may have heard of is called a fire scan, or it's a Spec CT combo. And this is where you put the Technetium 99 and CT scan together. And currently, you can order these separately. Many people will do the bone scan, or Spec scan, and then a CT. And the technology, you don't have to order them together. You can actually call your radiologist, and they'll actually blend them together. Take the 3D recon and the Spec scan and actually put it over top. And they call it a fire scan because they have a tendency to take, you know, the boring black and white and they put the color onto it. Patients love it. I think it's easy for them to say, yeah, that big white hot, yellow hot area, that's where it hurts. It seems to explain things better to patients. There's not as much scientific component to it. Here's how we use MR, and we grade them 1 to 4. You'll hear this, you'll see the lesions graded. They'll call them the lesions, is it normal? Is it marrow edema, but intact cortical margins? So these are for stress fractures of the pars. So you'll actually see it before it actually develops a complete fracture of the periosteum and cortex. So, by the time you have a complete fracture and then complete fracture with no molar edema, it's going to be a chronic fracture as opposed to fluid being acute. Okay. So here's a fracture. There's no edema, so it's to be considered a grade 4. Here's a grade 3. You can see some edema at the fracture site. Okay. So treatment: rest 3 months, CT scan repeat, shows early progressive staging of lesion, terminal lesion. If it's a terminal lesion, rest until pain subsides. So if you've got something that's old and chronic, you're basically going to rest it and protect it until they're pain-free, get their core strong, and off they go. If there's a chance to heal it, we're going to try to let that get bone-to-bone healing, or what we call osseous formation versus fibrous formation. So it's controversial. Where does the brace fit into this? Okay, remember, we talked about the use of bracing with scoliosis and kyphosis. This is different. This is really, do you need this for a chronic lesion? It's only for pain control. If someone's a football lineman and they've got a terminal lesion, it's really chronic, you're going to brace them and let them go and play football as long as they're protected. If the brace usually helps them 90% of the time. They can play in the brace during the season. Once they come out of the season, they come out of the brace. The goal is to get them strong, and eventually they won't need the brace. If it's not a terminal, it's a new case, then the questions are, is bracing helpful with or without? So we'll talk a little bit about brace, no brace, hard versus soft. So here's some data stuff. 33 patients with 60 spondy, so they individualized the spondies to either unilateral or bilateral. The prospective study, and they excluded any terminal lesions. So anyone with stage 4 was not included. Both bilateral or unilateral. Each lesion was staged by CT and MR. And what they were looking for was early on, the number of defects, and where they picked them up early, when they picked them up with changes on MRI, no changes on MRI, and terminal, which means it was totally quiet. So you could see the no hypersensitive specific on the MRI was near the ending of the acute phase. So you can see in the acute, which is here, the very acute, if you caught it, okay, and you braced them, union rate was 94% at 3 months. Here, union rate was 2/3 at 5 months, and then drops down to these, no union, and only 25% at 6 months. So the sooner you find it in this, that it's in this bone marrow edema, the sooner you brace it, the better this seems to be. Okay, this is also the same study from Saro out of Japan, where they looked at the stage. What was this one? This was union rate on 8 to 17. This was the study was 7 to 17-year-olds, and once again, looking in this follow-up study, the union rate was much higher the earlier you detected it, and with bone marrow edema. So you got a chance to have bone-to-bone healing, which is always better than a fibrous union, which would occur here or not at all. Klaines Metaanalysis looked at 17 studies, 16 case series, mostly retrospective, looking for various combinations of brace, rest, and PT. Here's the take-home point. Good clinical outcomes. So good was anything less than bad, less than no change. Good meaning that improvement in pain, improvement in function. 86% without the brace, 89%. Not statistically significant. So going from this meta-analysis, bracing is questionable for spondylolysis and spondylolysis. So if you decide to do bracing, okay, I've hopefully made it clear as mud. You want to rest them until their pain gets somewhat better. Physical therapy can help that. You have low impacts, cardiovascular training, core strengthening, advanced core and stability work, and sports-specific training to emphasize about proper biomechanics. Xrays for most of the very young, and especially for progression of the spondylolisthesis. Unilateral defect in very young, not older. And then it's usually every 6 to 12 months until skeletal maturity. CT, if you really wanted to check and expose them to this, usually you can get the pictures. Now, even obliques, AP and lateral spine does not have a ton of ionizing radiation. It's about 3 to 4-fold with an oblique, and about 100-fold of a simple X-ray with a CT scan. So be careful about ordering a lot of obliques and a lot of CT scans. When do you return to sport, with or without a brace? Big question. You have a terminal lesion or you're trying to heal them. Demonstrate healing on CT or MR. How are you going to prove that they're better to take them out of the brace, or to let them go to full impact for football or soccer? Are they cardiovascularly in shape? Their core is stronger? Because a lot of them, these kids are growing, their hamstrings are all out of whack, their core is off. All these things we want to get better before we send them back. Usually takes 2 to 4 months till they get complete. Sometimes with terminal cases, we'll see them within 5 days of bracing, they feel great. In those cases, we'll get them back much sooner. Spondylolisthesis, they're going to have back pain. They may radiate to the butt. Very rare do we have any big neurologic issues because of the posterior and anterior elements are moving apart. They're not compressing the neuroforamina. They're not compressing the nerve roots. The increased lumbar lordosis, hamstring tightness, lumbar tenderness, palpable step off is rare, but you can do it in very thin people. You can feel it. You're going to image these, X-ray and MRI, relative rest, rehab, and surgery. I've only had one patient with spinal apoptosis, and they grade the slippage by quarters. So a quarter of the vertebral body above has moved up 25%, is grade 1, 50%, grade 2, 75%. When you get to 100%, then it basically the spine the vertebral body drops off the ledge, and that's called spinal apoptosis. And I had one, it was a young lady in marching band that I never asked what instrument she played. I'll never forget this. Small little thing, and of course I thought she played the piccolo or the clarinet or the snare drum. She carried the bass drum, big thing with the shoulder straps, and she was like 5 foot nothing. And that just caused so much torque on her lumbar spine. I want to thank you guys for the time. Here's my references for the scoliosis and the spondyloarthropathies. And eventually, some of you will end up like me. This is my kids when I started as a young faculty member. Here they are today as an old faculty. So I put down my cell phone number and my email. If you have any questions, I'll leave that up. Any questions in the chat? We're right at an hour.
Hey, Mark, that was awesome. Thank you.
That's a lot of information.
Yeah, we're a little over already, but I've got a few questions I wanted to try to get in. I'm going to really sure the name of this brace, Rigaud Chenot.
Yeah, perfect. Rigaud Chenot.
How do we order and appropriately size that for their patients?
So when I started using this brace about 4 to 5 years ago, there was only 6 people in America that were certified to make this brace. That has since changed. If you type in Wood Rigaud, Scott Wood was an orthotist from UCSF. So anybody in UCSF system have Scott Wood in the Bay Area, I would use him. He brought this to the United States and basically trained as many orthotists that would do this, because all this you got to do is basically you take the X-ray you give them, they do this body scan to look at body contour, and then they make this brace, and it costs thousands of dollars. It's not cheap. You're gonna have to do paperwork for it. But if you just do Wood Rigaud Chenot, or just Rigaud Chenot brace, and then type in your town or city in Dr. Google, usually that pops up. If anybody needs, they can email me, and I know a lot of the different orthotists on the Eastern Seaboard that are doing this. The nice thing is more people are getting trained in this. It's becoming much more accepted. Paul Sponseller wrote a paper about 4 years ago comparing the Boston brace with the Wood Rigaud. Paul Sponseller is the chief of pediatric orthopedic spine surgery at Johns Hopkins. So that carried a lot of weight in the spine community. So this is really being accepted now.
Thank you. And can you skip the CT and go straight to MRI for spondylolysis, or do you recommend always getting the CT scan first?
That's a very good question. I mean, it depends on the kid and what I think. If if my pretest probability, I think this is old, and we're not going to go for bony healing. I may go with an MR because I'm looking for bone marrow edema. And that's, if I think it may be new, we're going to want to go for healing. I may go with a Spec and a CT, and then because then I can follow up the CT in 12 weeks, 3 months, and see if we get bone to bone healing. Another thing that I didn't mention here was the bone stimulators, like the ultrasound or electronic bone stimulators like Xrays and some of the other ones out there. In thinner patients, we've used them and they have really helped get that bone to bone healing.
Okay. Back to scoliosis. How does the brace correct the curve from a biomechanical standpoint? Does the physical realignment of the curve help train surrounding musculature to strengthen and keep the spine in a straightened position?
So what's happening, from the best that I can figure, looking at all my patients that have had this brace, different than a TLC Boston brace, is that the Boston brace is a tube, just a plastic tube that they wrap around in Velcro. With the Go brace, you're taking the tube and you're causing a little twist. So you're pushing on the convexity of the rib pump. And as you have vertical growth, it's stabilizing that posterior concavity, and the convexity will have freedom to grow. So by stabilizing the concavity, the convexity will grow. I mean, stabilizing the convexity, the concavity will grow. So the deficit will fill out. Incorrect.
Okay. And any comments on PT? Do you refer patients for Schroth or other particular specific specialists?
So I use Schroth primarily after bracing because they're coming out of a bracing period. And that bracing period anywhere between 4 months to a year and a half. And if they're wearing it, they're probably their core strength is sort of weak, even though we have them do core for the hour or two that they're out of the brace. But remember, we're talking about 13 to 15 or 16-year-old young ladies, and getting them to wear the brace and doing the exercises is a gargantuan task with parental and physician involvement. So if you can get them to do that, that's great. But many don't. So then we are getting them into therapy at the very beginning of the brace to try to teach them, and then at the end of bracing for about a month to get them strong. And what we don't want to happen is you take them out of a brace and they're all jelly belly and they don't have a good core and they slouch and like I'm doing right now, and they're not sitting up like this, and everything goes to hell in a handbasket.
Okay. We do have more questions coming in, but we're already over time. So thank you so much, Dr. Lavallee, for that.
They can actually email me their questions if they want, or you can, you can email them and I'll answer them. I apologize for going over, but it's something I'm very passionate about. I love treating these patients. I see Pierre Rosier at UMass and Mike Galbraith and so many names up there. So thank you guys for giving me an hour plus of your time. If I can be of any assistance, don't hesitate to reach out to me.
Thank you. As a reminder, next week, November 3rd, there will be no lecture, but we will return on November 10th with a keynote lecture, which is Heading in Soccer. We look forward to seeing you then.
Bye, everyone. God bless.